This program is brought to you by Emory University.
Our speaker this morning is Dr. Anurag Mehta. Anurag is one of our third-year fellows in the clinical investigator track. Anurag went to medical school in India, in New Delhi. He did his residency in Dallas at UT Southwestern, came here and did 2 years of research with Drs. Sperling and Kayumi, and is now finishing up his first clinical year. And as you can see, he's going to talk to us about lipoprotein little a. Anurag.
Thank you for the introduction, Dr. Williams, and good morning, everyone. Today, I'll be talking about lipoprotein little a and atherosclerotic cardiovascular disease. I'm going to briefly walk through the history of the discovery of lipoprotein A and the role it plays in atherosclerosis, as well as recent discoveries and investigations which are providing a new twist to this age-old saga. I have no disclosures. These are the objectives of my talk. First off, I will provide a brief overview of lipoprotein A structure, metabolism, and measurement assays. Followed by this, I will be discussing the role of lipoprotein A in the pathophysiology of atherosclerotic cardiovascular disease. The third objective will be reviewing the clinical significance of elevated lipoprotein A levels in both primary prevention settings, so patients who do not have cardiovascular disease, as well as secondary prevention settings in patients who have cardiovascular disease. And lastly, I will discuss the impact of common lipid-lowering use therapeutics on lipoprotein A levels and a new targeted therapy which is directed towards lowering lipoprotein little a. Before I move on to the main presentation, I would like to briefly talk about this case of a 54-year-old gentleman that I took care of as a CAT fellow. He presented to the emergency department with chest pain, was noted to have an NSTEMI, and on coronary angiography, he had a culprit lesion in his proximal LAD, but also had non-obstructive coronary artery disease involving the rest of his territories. His past medical history was significant for hypertension, which was diagnosed 4 years ago, as well as obesity. His family history was significant for a paternal history of a fatal MI at the age of 55 years, so very similar to his age. And he denied smoking, drinking, or drug use. He briefly worked as a warehouse manager here in Atlanta and had served in the military for 4 years. He is married and has 2 teenage children. He leads a sedentary lifestyle and enjoys eating red meat and barbecue, along with takeout food a couple of times a week. His only medication is lisinopril 20 milligrams daily. His physical examination was significant for an elevated blood pressure and an elevated BMI. His cardiovascular examination was benign, and he only had evidence of some central obesity on exam. His labs showed normal complete blood count, serum chemistry, and liver function tests. His fasting blood glucose was slightly elevated to 106 milligrams per deciliter. And this is his fasting lipid profile. As you can see, his total cholesterol was 250 milligrams per deciliter. His HDL cholesterol was a little low at 42. His triglycerides were 160, and his LDL cholesterol, calculated using the Fried-Wald equation, was elevated at 170 milligrams per deciliter. And we sent an assay for lipoprotein little a, and in a couple of days, it resulted as being elevated at 72 milligrams per deciliter. At this point, I thought of 4 important and perhaps more clinical questions that are pertinent to this case, and these are listed here. The first one being, what is lipoprotein A? And does it influence atherosclerosis? And what are the mechanisms by which it does that? And should lipoprotein A level have been measured in this patient? And lastly, what can be done about elevated lipoprotein A in this particular scenario? And these clinical questions are tied to the 4 objectives of my talk, and I will go through them one by one. The first objective is the overview of lipoprotein A structure, metabolism, and measurement assays. Lipoprotein A was discovered back in 1963 by Dr. Berg, and he recognized the particle as an antigenic variant of low-density lipoprotein. And we are all familiar with LDL, and we know that it is pathogenic and is causative for atherosclerotic cardiovascular disease. The figure on the left is a schematic representation of the lipoprotein A molecule, and I will take a deeper dive into it in the next slide. This is a zoomed in version of the schematic, and I would like to spend a couple of minutes to review the structure of the lipoprotein A particle. The spherical structure here in the center is an LDL-like particle, and as you can see, the green structure here that traverses pretty much through the particle and serves as a structural scaffold for the lipids that are contained here is an apolipoprotein called ApoB100. And this is an apolipoprotein which is found on LDL particles as well, and it provides scaffolding to multiple different kinds of lipid molecules, including cholesterol esters, triglycerides, phospholipids, free cholesterol molecules, and oxidized phospholipids. So this moiety by itself resembles very closely an LDL particle, but the special feature about lipoprotein A is that there is an additional apolipoprotein which is covalently bound to this LDL-like particle. And this structure is called apolipoprotein a, and it comprises of an inactive protease domain, which is here on the left, and there are these amino acid sequences which are known as Kringle repeats, which are all listed here. Starting from the bottom, this first molecule is Kringle 5, and there are subsequently various subtypes of Kringle 4. And as you can see, there is a Kringle 4 type 10, 9, 8, 7, 6, 5, 4, and 3. And then there are multiple copies of Kringle 4 type 2, which is of both pathologic importance as well as important from a measurement perspective. And there's a single copy of Kringle 4 type 1. And the number of copies of Kringle 4 type 2 dictates the size of the lipoprotein A particle as well as the plasma concentration. And there are two Kringle 4 repeats that are important. The first one being Kringle 4 repeat 9, which forms a disulfide bond between the ApoB100 of the LDL-like particle. So both these moieties are covalently bound to each other. And the second important Kringle is Kringle 4 type 2, which is covalently bound to oxidized phospholipids, which play an important role in atherosclerosis. The second figure here shows an important evolutionary similarity between the zymogen plasminogen and apolipoprotein A. It is believed that from an evolutionary perspective, apolipoprotein A was actually derived from changes in plasminogen. And as you can see, plasminogen contains an inactive protease domain, which is converted into its active form when it gets converted into plasmin. And a similar protease domain is also found in apolipoprotein A as well. The differences between the two molecules are that in plasminogen, there are 5 different types of Kringle repeats, whereas in ApoA, Kringles 1, 2, and 3 are missing, and it's only Kringle 4 and Kringle 5, but Kringle 4 has the 10 different subtypes that I was just mentioning a minute ago. And the structural similarity between the two molecules is of importance, as we'll review in just a second, in terms of the role of lipoprotein A in atherosclerosis. This schematic here shows a brief overview of lipoprotein A synthesis and clearance. The major organ which is involved in lipoprotein A metabolism is the liver. And here you can see that there is a hepatocyte, and within the nucleus, the LPA gene, which codes for the apolipoprotein a, is located on chromosome 6. And through the process of transcription, it produces an LPA mRNA, which is After transcription, it gets translocated to form the apolipoprotein A molecule, which is synthesized and folded and secreted from the Golgi apparatus and fuses with the LDL-like particle. The exact site where apolipoprotein A and lipoprotein A and the LDL particle are fused together is unclear. There is a lack of investigation in this area at this point, and it's either in the hepatocyte or right outside the cellular surface. And this leads to the assembly of the lipoprotein A particle, which can be cleared by multiple different mechanisms, which involve the LDL receptor, the scavenger receptor B1, a receptor which plays an important role in atherosclerosis, as well as dedicated receptors to plasminogen because of the structural homology between apolipoprotein a and plasminogen. And the particle is recycled or it gets degraded within the lysosome. And this schematic here shows the importance of the LPA gene and its role in modulating the levels of lipoprotein A. And I will walk you through this schematic from this recent publication that came out earlier this year. So 2 copies of the LP are present on chromosome 6, allele 1 and allele 2 here. And the important thing to remember is that both alleles contribute to the levels of lipoprotein A. So this is an autosomal codominant inheritance. And in the example that is shown here in this figure, there is the allele 1 has a small ApoA allele. And what it means is that there is only 10 copies of the Kringle4 type 2 on this gene, and 1 copy each for Kringle4 type 1 and the rest of the Kringle4s as well as Kringle5. The second allele is larger and it contains 25 copies of the Kringle4 type 2. So the lipoprotein A particle which is produced by the first allele is smaller, whereas the particle which is produced by the larger allele is larger. And because of the laws of molar concentrations and the way in which these particles are produced, smaller isoforms produce higher concentrations of lipoprotein A in the plasma. So as you can see, allele 1 here, which produces a smaller isoform, produces a lipoprotein A concentration of close to 60 milligrams per deciliter, whereas the larger isoform produces lipoprotein A, which is close to 10 milligrams per deciliter. And in the given organism or human being, the plasma level of lipoprotein A will be a combination of the levels which are produced by these 2 alleles. So here in this scenario, it will be close to 70 milligrams per deciliter, very similar to our patient here. And the key thing to remember is that nearly 90% of plasma lipoprotein A levels are determined by genetics. Moving on to the measurement of lipoprotein A, there are 2 commonly available assays that are used in clinical practices. The first set of assays are known as mass assays, and this is a kind of assay that we use here in the Emory system as well. And it reports the levels of lipoprotein A as milligrams per deciliter. The key thing to remember about this assay is that it measures the total mass of lipoprotein A within the peripheral circulation. So this includes the apolipoprotein A along with all of its kringles, as well as ApoB100, along with all of the lipids that are associated with this molecule. A key feature of these assays is that over time, these have become insensitive to the number of kringled repeats that are present on apolipoprotein A. So we are now able to measure lipoprotein A with higher fidelity. And these assays are more commonly available. And as I was mentioning, we have the same assay here in the Emory system, as well as at the VA and at Grady too. The second kind of assay that is available are the particle assays, which report results as nanomoles per liter of lipoprotein A. And this gives you an idea of the total lipoprotein A number. So the number of particles which are circulating in the peripheral circulation. So it's different from the mass assay, and it is regarded as a better assay if we consider the pathophysiologic role of lipoprotein a, because it focuses on the number of particles in the circulation, which are thought to be related to the degree of atherosclerosis. And these assays are less commonly available. One important thing to remember about these two is that the measurements made from one assay cannot be interchanged into the other one by just using a mathematical equation. So, commonly in the past, people used to use a factor of 2.5 to convert measurements which were made in milligrams per deciliter using a mass assay into nanomoles per liter, but that is not recommended. So that was our first objective, the overview of LP structure, metabolism, and measurement. And now I will briefly go over the role of lipoprotein A in atherosclerosis pathobiology. And I would like to start by mentioning that lipoprotein A influences atherosclerosis through multiple non-redundant pathways. And these pathways are listed in this schematic. The exact mechanisms need to be elucidated further, but one of the key mechanisms by which lipoprotein A is thought to cause atherosclerosis is that it is pro-atherogenic. And this makes sense because a major component of the particle is this LDL moiety, and we have overwhelming evidence now to suggest that LDL particles are causative for atherosclerosis, and the mechanism involves binding to the vascular endothelium, upregulation of cellular adhesion molecules, proliferation of smooth muscle cells, formation of foam cells within the arterial wall, a necrotic core formation, lesion calcification, and then disruption of the lesion, which leads to atherothrombotic events. So the LDL particle within lipoprotein A is causal for atherosclerosis. And in addition to that, recent studies and studies from the past suggest that apolipoprotein A also plays an additive role in its additive pro-atherogenic role, and a primary determinant of that are these oxidized phospholipids, which are bound to the apolipoprotein little a particle. The second mechanism by which lipoprotein A is thought to cause atherothrombotic disease is that the particle is prothrombotic, and this traces back to the structural homology between apolipoprotein little a and plasminogen, and it is thought that the particle decreases plasminogen activation, decreases fibrin degradation, as well as increases platelet reactivity and responsiveness, which are key for promoting thrombosis in atherosclerotic lesions. And the last non-redundant mechanism by which lipoprotein is thought to cause atherosclerosis is by promoting inflammation. Oxidized phospholipids, again, play an important role in driving the inflammatory cascade in atherosclerosis. There is increased expression of chemokines as well as interleukin-8, and these promote atherosclerosis as well. And now I will move on to the clinical significance of elevated lipoprotein A level. I will start off by briefly discussing the clinical practice guidelines which are available at this time and what are their recommendations regarding checking lipoprotein A levels in our patients. The first one here is the American Heart Association, American College of Cardiology, Multi-Society Cholesterol Management Guidelines, which were released back in 2018. And these guidelines recommend that lipoprotein A levels can be measured in patients who have family history of premature atherosclerotic cardiovascular disease. And this is similar to our patient who had a paternal history of a fatal MI at the age of 55 years. And also patients who have a personal history of premature ASCVD and do not have major risk factors are also candidates in whom lipoprotein A levels can be measured. The second guideline here is from the European Society of Cardiology, which was released a year after the American guidelines. And these guidelines have slightly expanded the role of checking lipoprotein A. They recommend that lipoprotein A levels can be checked at least once in a lifetime to find individuals who have extremely elevated lipoprotein A levels, which are greater than 180 milligrams per deciliter. And they think that this would have important implications for discussing cardiovascular risk in these individuals and the use of lipid-lowering therapies. Similar to the American guidelines, the Europeans also recommend measuring lipoprotein little a in individuals who have family history of premature cardiovascular disease. And they also mention that select individuals between moderate and high risk can also be candidates in whom lipoprotein A levels can be measured. And most recently, pretty much the same year as the European guidelines, the National Lipid Association released a scientific statement solely focusing on lipoprotein little a, and they further expand the patient pool in which checking lipoprotein A might be reasonable. And these patients now include those with family history of premature ASCVD, personal history of ASCVD, patients who have primary hypercholesterolemia with an LDL cholesterol greater than 190, those at borderline 10-year ASCVD risk of 5 to 7.5%, those with less than anticipated lowering of LDL cholesterol with lipid-lowering therapies, and also in cascade screening for familial hypercholesterolemia. Out of all of these guidelines, I would like to highlight the 2018 AHAIACC cholesterol management guidelines, and you are probably familiar with this schematic. It's a little busy, but I will walk you through some of the key aspects of it in the next few seconds. This schematic is focusing on individuals in the primary prevention group. So these patients do not have atherosclerotic cardiovascular disease. And after removing individuals who have really elevated LDL cholesterol levels greater than 190, individuals with diabetes, and then focusing on those between the ages of 40 to 75 years, the AHAIACC guidelines recommend estimating the 10-year risk of an ASCVD event using the pooled cohort equations. And this is something that we very commonly use in our practice. For example, in EPIC, there is kind of a smart phrase which is integrated that automatically calculates the 10-year ASCVD risk. And the current guidelines recommend that individuals with 10-year risk between 5 to 7.5 are in the borderline risk category, and those between 7.5 to 20% are at intermediate risk category. And in these individuals, these guidelines recommend that we should have a risk discussion with the patient. And after estimating the 10-year risk, we should consider focusing on risk enhancing factors, which I will highlight in just a second. And this table here show the ASCVD risk enhancers, and some of these are commonly assessed during our process of history taking, and includes family history of premature ASCVD, persistently elevated LDL levels, chronic kidney disease, metabolic syndrome, conditions specific to women, including preeclampsia and premature menopause, inflammatory diseases like rheumatoid arthritis, psoriasis, HIV, South Asian ancestry, which is a high-risk ethnic group, persistently elevated triglyceride levels. But I would like to focus your attention here at the bottom on these other markers of increased risk. And what is highlighted here is a lipoprotein little a level greater than 50 milligrams per deciliter. So this is from the mass assay, or greater than 125 nanomoles per liter, which is from the particle assay. So if you have a lipoprotein little a measurement in the primary prevention setting, which is higher than this threshold, then you can consider the use of statin therapy in these individuals, because this is a risk enhancing factor which is associated with an increased risk of cardiovascular events down the line. And if we use this cutoff of 50 milligrams per deciliter, there is an estimated 1.43 billion individuals across the world who have an elevated lipoprotein A level. As you can see, this burden of elevated lipoprotein A varies by continent and varies by ethnic group, which I will talk about in just a few minutes. But the highest proportion of people who would have the burden of elevated lipoprotein A would be in Africa, where nearly 30% of the entire continent's population would have an elevated lipoprotein A. And this is followed by South Asia, where nearly 25% of the individuals would have an elevated lipoprotein A, followed by other continents and other ethnic groups, as are described here. The graphs here show the population distribution of lipoprotein A. And the reason why this is important to consider is because we just learned about the threshold that is used to define an elevated lipoprotein A level of 50 milligrams per deciliter. But it is important to remember that in the population, lipoprotein A levels are distributed in a highly skewed manner. And there is a right-sided tail to the distribution of lipoprotein A. As you can see here in these figures, there were greater than 500,000 people who were analyzed by Warville and colleagues back in 2016. So these are all of the subjects, and nearly half were women and half were men. And in the entire population and in both sex groups, the distribution of lipoprotein A was highly skewed with a right-sided tail. And this is in stark contrast to the distribution of LDL cholesterol, which is more so normal amongst all subjects, men and women. And the results of this study, which was published 5 years ago, show that if we use a cutoff of greater than 50 milligrams per deciliter, in this particular population, nearly 1 in 4 individuals would be classified as having an elevated lipoprotein little a level, which is consistent with the findings that we were discussing on the previous slide, which showed that the global burden of elevated lipoprotein A was also close to 25%. Another key thing to remember about the distribution of lipoprotein A levels in the general population is that there are stark race or ethnicity-based differences in circulating lipoprotein A. This is data from a study that was published in 2015 from the multi-ethnic study of atherosclerosis. MESA is a population-based epidemiologic cohort, which is based in 6 field centers within the United States. And they have recruited participants from 4 different race or ethnic groups. And highlighted here are Black, Caucasians, Chinese, and Hispanics. And as you can see, the distribution of lipoprotein A within the 4 ethnic groups is similar in the sense that it is skewed with a tail towards the right. But the median levels of lipoprotein A in Blacks are almost 3-fold higher as compared with Caucasians, with Chinese, and with Hispanics, who all end up having similar lipoprotein little a levels, whereas in Blacks, the median level was nearly 2 to 3-fold higher. And this has important implications for risk prediction that I will go over in just a second. So now that we know that there is a designation for an elevated lipoprotein A level of greater than 50 milligrams per deciliter, why does it matter? And these are the results from a seminal meta-analysis, which was published slightly over a decade ago by the Emerging Risk Factors Collaboration. This group studied participants of 36 studies, over 125,000 individuals, and found that there was an uptake in the risk of non-fatal MI and CAD-related death that happens around this threshold of 50 milligrams per deciliter. And this was one of the first studies that would comprehensively show that there is an increase in risk, which is associated with high lipoprotein A levels. But one of the key points to remember about this study is that most of the individuals studied in this analysis were whites and of European descent. And that is why it is important to understand that does elevated lipoprotein A have the same meaning in terms of cardiovascular risk across ethnic groups? And this important question was answered by the study that was done a decade ago by Salim Virani and colleagues. And here, although the tables are a little busy, I would like to highlight that the study focused on participants of the Atherosclerosis Risk and Community Study, or ARIC. ARIC study is similar to the MESA study that we were just talking about, but it is larger, approximately 13,000 participants in this study, and they were recruited back in 1988 to 1990. So they have a long duration of follow-up for adjudicated cardiovascular events. And the novel technique that the investigators here used was focusing on race-specific quintiles. So they separated out Black participants and white participants during the analysis. And as you can see, there were nearly 3,500 Black participants in the AHAIACC study and nearly 10,000 white participants. And similar to previous analyses, they found that the median level of lipoprotein A amongst Blacks was nearly threefold as compared to whites. And when they focused on the race-specific group and constructed these race-specific quintiles, they observed that a high level, so in the top quintile or top 20%, which for Blacks would be a level greater than 24 milligrams per deciliter, was associated with the risk of cardiovascular disease, coronary heart disease, as well as ischemic strokes. And a similar finding was also observed in whites as well. So this paper established that, or kind of took care of the limitations of previous analysis, which focused primarily on whites. But this paper shows that an elevated lipoprotein A level, which is considered in the context of race or ethnicity, is associated with an increased risk of cardiovascular events down the line. And after this, I will fast forward to some of the more recent work that I have been able to participate in and contribute to. And this is fast forwarding a decade. And one of the questions that we tried to answer, and this was in collaboration with Dr. Virani and other investigators that I've had the opportunity to work with, the question that we wanted to answer was, lipoprotein A levels are nearly 90% determined by genetics, and family history of cardiovascular disease is a proxy for genetic risk of cardiovascular disease. And if you remember from the table that I'd shown you from the 2018 cholesterol management guidelines, both elevated lipoprotein A and family history are considered as risk enhancers for cardiovascular disease. And the question that we wanted to answer was that, are these markers redundant? And they do not, and the fact, do they provide information which is unique to each of them, or are they redundant, and when considered together, they would not provide unique information towards cardiovascular risk? And what we found was that, in fact, both these markers are independently associated with the risk of cardiovascular disease. The table here shows the adjusted hazard ratios for atherosclerotic cardiovascular disease risk. And as you can see, family history of coronary heart disease was independently associated with an increased risk, and so was race-specific elevated lipoprotein A level, quintile 5, or the top 20%. And we performed this analysis using two different cohorts. The first, the primary cohort was the AHAIACC study, which had nearly 12,000 participants and had Blacks and whites in the ratio of 3:1. And we replicated these results in an independent cohort known as the Dallas Heart Study, which comprises of white, Black, and Hispanic participants. And we were able to show similar results in both of these cohorts, highlighting the fact that both family history and elevated lipoprotein A are non-redundant markers of ASCVD risk. Another important takeaway from this study was that both elevated lipoprotein A and family history were not only independent of each other, but they were additive for predicting the risk of cardiovascular disease. In the Kaplan-Meier curve here to the left, you can see that in this blue line up on the top, these are individuals who had a family history of cardiovascular disease and also had an elevated lipoprotein A level within the top quintile for that specific race ethnic group. And they are at a significantly higher risk of cardiovascular disease as compared to participants here in purple, who, number one, do not have elevated lipoprotein A and do not have a family history, but also when compared to individuals who would have just one of these risk factors. So just a family history of cardiovascular disease, but a non-elevated level, or an elevated lipoprotein A level, but lacking a family history. And these results kind of remain consistent when we analyze these using multivariable adjusted Cox models, where we control for several cardiovascular risk factors as potential confounders. And this was the takeaway from our paper, which highlights that both lipoprotein A and family history of heart disease are independently associated with cardiovascular risk down the line, and they have an additive joint association with each other, such that the presence of both risk markers identifies individuals at increased cardiovascular risk. And if you see these patients in your clinical practice, number one, they would be at high risk for cardiovascular disease down the line, as the study shows, but they might be the appropriate candidate for modulating the cardiovascular risk factors, including healthy lifestyle and consideration for statin therapy use. Kind of building on this research project, a second analysis that I've been involved in focuses on lipoprotein A and coronary artery calcium scores. And as we've reviewed in this talk, elevated lipoprotein A is associated with CVD risk, and so is an elevated CAC score. Here, we've been using these frequently, especially in people who do not have cardiovascular disease, so primary prevention populations. And the 2018 guidelines, 2018 American Guidelines for Cholesterol Management highlight that lipoprotein A is a risk enhancer, and coronary artery calcium score is actually a decision-making aid when it comes to prescribing statin to our patients who are not taking statins at that given standpoint. And we wanted to answer the question that when we consider this risk enhancer and this decision-making aid, is there any benefit of measuring both of these risk markers, and what kind of results we would see when both of these risk markers are considered together? And this analysis has not been published as yet, but here we started two different population cohorts, the MESA, which has participants of 4 different ethnic groups, as well as the Dallas Heart Study, which we used as our replication cohort and had participants from 3 different ethnic groups. And what we found interestingly was that both lipoprotein A and coronary artery calcium score are independent of each other in terms of their association with cardiovascular risk. And these findings were consistent in both of the cohorts that we studied. So if you have an elevated lipoprotein A level, it is going to lead to a higher risk of cardiovascular disease independent of your CAC score. And the vice versa is also true. If you have an elevated CAC score, it doesn't matter what your lipoprotein level will be, but you will be at an elevated risk of cardiovascular events down the line. And this is the Kaplan-Meier curve from this analysis, which shows that in the blue line here, individuals who have an elevated lipoprotein A level greater than 50 milligrams per deciliter and a CAC score greater than 100, which we commonly use for guiding our decisions about statin therapy initiation. The presence of both of these risk markers is associated with a significantly increased risk of cardiovascular events over 10-year follow-up. But when you consider people who have an elevated CAC score but a non-elevated lipoprotein A level, they are still at an intermediate risk intermediate 10-year risk of cardiovascular events. But impressively, if you do not have an elevated CAC score, it does not matter what your lipoprotein A level is, especially when you're considering individuals for 10 years of follow-up, where both of these lines in the survival analysis are almost parallel to each other and kind of go together with each other, which is a unique finding and further highlights the role of coronary artery calcium score in de-risking individuals, where individuals who do not have coronary artery calcium or have a low score have this protective effect which is associated with it, and they are at a decreased risk. Although this is not no risk, this is at a decreased risk as compared to these other two populations. Moving on from the primary prevention setting to the secondary prevention setting, these are the results from the Odyssey Outcomes trial. And just to recap, Odyssey Outcomes was a large phase 3 trial of Alirocumab, and nearly 19,000 participants were studied in this trial. And these patients were post-ACS, so a high-risk group who were randomized either to receive the PCKS9 inhibitor Alirocumab or placebo. And what the authors here, Dr. Vera Bettner and colleagues, have shown is that the baseline level of lipoprotein A in these individuals who are post-ACS, these are associated with the risk of cardiovascular events down the line. As you can see, here the uptake point is somewhere close to 25 to 50 milligrams, between 25 to 50 milligrams per deciliter, but there is this steady increase in cardiovascular risk, which is associated with high lipoprotein A levels in individuals who are post-ACS. And the second study, which was very recently published, highlights the difference between primary prevention and secondary prevention. This is data from the UK Biobank. Over 450,000 individuals were studied in this analysis. The key difference here is that the lipoprotein A was measured using a molar assay. So this is the one which the results are reported in nanomoles per liter. And the authors used a cutoff of 150 nanomoles per liter for this analysis. On the left here is the primary prevention population. So these people did not have atherosclerotic cardiovascular disease. And the authors found that nearly 12% had an LPA greater than 150. And there is a separation in cardiovascular risk, where in the red line are the individuals with high lipoprotein A level, and they are at a high risk of cardiovascular disease. And the people who have low lipoprotein A levels were at a decreased risk. And in contrast, here on the right, these are individuals in the secondary prevention cohort. So they had atherosclerotic cardiovascular disease at enrollment. And the key differences are nearly 20% had an LP greater than 150 nanomoles per liter as compared to 12%. So somehow this population is selected for higher lipoprotein A levels. And also, one of the key things that came out of this analysis is that maybe it's limited because the sample size here is much smaller as compared to the primary prevention cohort. But the risk associated with a high lipoprotein A level after you've had atherosclerotic cardiovascular disease might not be as strong as what you observe in the primary prevention population. But these findings are speculative and need to be analyzed in more detail moving forward. Now that I've reviewed the clinical significance of elevated lipoprotein A level, I will move on to the last objective of my talk, which is focusing on the impact of lipid-lowering therapeutics on lipoprotein A levels. And I will start with the most commonly used lipid-lowering therapy that we prescribe in our clinics and perhaps all across the world, statins. And these are findings from the study that was published 3 years ago, which sought to analyze the association of an elevated lipoprotein A level. And here they used a cutoff of 50 milligrams per deciliter, which is consistent with the US guidelines. They sought to understand the association of elevated lipoprotein A in individuals from 7 different statin trials. And they wanted to see if there's a difference in the association of lipoprotein A with cardiovascular risk among those receiving statin or amongst those receiving placebo. And they found that although there is significant overlap here in the hazard ratio, regardless of the fact that if you're on a statin or not on a statin, lipoprotein A levels are associated with cardiovascular risk down the line, and perhaps more so in individuals who are receiving statin therapy. As you can see here, the multiplicative interaction here is statistically significant. And although there's a significant overlap, the hazard ratios are slightly higher for those receiving statin as compared to those receiving placebo. Which takes me to this controversial paper that was published last year by Dr. Sam Semikas and colleagues. And they studied individuals with from six different trials, and they wanted to demystify this impact of statin therapy on lipoprotein A. And the reason why this paper is controversial is that their takeaway from studying these 5,200 individuals is that statin therapy is associated with a slight increase, almost 11% increase in circulating lipoprotein A levels. And the reason why they say that this is mechanistically plausible is that here on the left, you see a liver in an individual who is not receiving a statin. Their plasma LDL cholesterol is 100 milligrams per deciliter, and their lipoprotein is 50 milligrams per deciliter. And as you can see, ApoB100 and apolipoprotein A combined within the liver to produce the LPA particle, and ApoB100 is used for creating the LDL particles. But once these individuals start taking a statin, there is a decrease in LDL cholesterol level, and there is an increased recycling of ApoB100. So there's perhaps more availability in the liver, which joins apolipoprotein level A to produce a slightly higher lipoprotein A level. This was one of the explanations which was offered by the authors, but the exact mechanisms for this are unclear. But one of the important takeaways was that this could be a potential mechanism responsible for the lack of decrease in LDL cholesterol that we see in patients who are statin non-responders. And I would like to highlight another key thing which I missed earlier, is that when we are using the Friedewald equation to find out a calculated LDL cholesterol level, the cholesterol in lipoprotein A is also considered within this equation, in the sense that if the LDL cholesterol is not directly measured and is just calculated, which is most commonly used in pretty much all of the assays that we use here, it will capture the cholesterol content of lipoprotein little a, because it shares the particle share structural homology with LDL cholesterol. And in the Friedewald equation, you do not consider directly measured LDL. It is just your triglycerides, your HDL, and your total cholesterol levels. So in individuals that we see in our clinic, where we find that despite the use of high intensity statin therapy, there is kind of a discrepancy in the decrease in LDL cholesterol, despite them being compliant with the medication, one potential mechanism for that might be an increase in lipoprotein A and the cholesterol that is associated with it, which is co-measured as LDL cholesterol. Moving forward to another class of lipid-lowering agents, the PCSK9 inhibitors, I would briefly like to mention results from two key trials. The first one here is the FOURIER trial, which studied Alirocumab versus placebo for reducing cardiovascular risk in individuals who have cardiovascular disease. They studied nearly 25,000 individuals, and the findings here are from a recent publication from a couple of years ago. And what they studied was the impact of PCSK9 inhibitors on circulating lipoprotein A levels. And they classified individuals by quartiles of lipoprotein A levels. So quartile 1 being the lowest level, quartile 4 being the highest level. And they found that Alirocumab decreases the circulating levels of lipoprotein A. And this decrease in level is, as you can expect, is dependent on your baseline levels of lipoprotein A, with an increase in the reduction that happens across these four quartiles. Key thing to remember here, repeat measurements in lipoprotein A level were made at 48 weeks, and they found that Alirocumab reduces lipoprotein A by 11 nanomoles per liter, which was close to 27% in this population. And as I was mentioning, this varies by baseline lipoprotein A level. These findings from 2019 were corroborated by these findings that were published last year, which were focusing on participants of the Odyssey Outcomes trial. And as you might remember, this is a trial that focused on a different PCSK9 inhibitor, Alirocumab, and the key differences being the size was slightly smaller with 19,000 participants. The follow-up measurement of lipoprotein A was made 4 months after, but similar results were seen in the sense that Alirocumab reduced lipoprotein A levels by nearly 23%. And similar to the FOURIER trial, this reduction in lipoprotein A level was dependent on baseline levels. So they also studied participants by quartile, and these green measurements here show that there is a reduction in lipoprotein A level, and the highest reduction is afforded in people who have high lipoprotein A level to begin with. And they also kind of highlighted that LDL levels, they were similarly distributed across the LP(a) quartile, and there was no significant change based on these quartile levels. And the reason why these findings are important is because from the Odyssey Outcomes trial, the investigators have also shown that the degree of reduction of lipoprotein A with the PCSK9 inhibitor Alirocumab might contribute to reduction in cardiovascular risk. And this is an argument which supports the lipoprotein A hypothesis, which suggests that lowering of lipoprotein A would be associated with cardiovascular benefits. And in this population, there is a suggestion that this might be possible when it comes to PCSK9 inhibitors. But a clear-cut answer to this question is currently being investigated, and I will move on to antisense oligonucleotide therapies, which are targeted towards lipoprotein A. The schematic here shows kind of the basic role of an antisense drug or an antisense oligonucleotide. It is administered, and in case of lipoprotein A, it enters the cytoplasm of a hepatocyte. And here, this antisense oligonucleotide binds to the mRNA of lipoprotein A gene. So the mRNA is produced after transcription of the DNA, and after the antisense oligonucleotide binds to the mRNA, the complex is rapidly degraded by a ribonuclease H1, and there is no translation of this mRNA to produce the protein. And since the protein is not produced, the levels in the cytoplasm as well as in the plasma are expected to fall. And this kind of therapy has been investigated over the past few years. The first one here is a phase 1 trial that was conducted earlier in the 2010s and was published in 2015 here in Lancet. And what you can see here is that the investigator studied 3 different doses of an antisense oligonucleotide, and with a 100 milligram dose, they observed a nearly 40% reduction in lipoprotein A level that happened at 6 weeks. With a 200 milligram dose, this corresponding reduction was almost 60% and nearly 80% with the 300 milligram dose. And the peak effect happened around the 6th week, and after which the drugs were discontinued and the level started to rise, as you can see in this graph. And this was followed by a slightly larger phase 2 trial, which was published back in 2016. And here there are similar results if you compare these 2 graphs, but there were 2 separate cohorts. The first one had slightly elevated lipoprotein A levels, and the second cohort has very high lipoprotein A levels. But this antisense oligonucleotide resulted in a very significant reduction, 70% in the first cohort, actually 67% in the first cohort and 72% in the second cohort. And the peak effect happened with the continuation of this medication up to 12 weeks. And once it was discontinued, the levels went up. And this brings us to this most recent trial, phase 2 again, of an agent now known as Pelacarsen, which is an antisense oligonucleotide that directly targets lipoprotein A. And these findings were published last year in the New England Journal. And the authors here studied different formulations of the antisense oligonucleotide, and they saw that depending upon the dose of the agent, there was a dramatic reduction in lipoprotein A level, with reductions as high as 70 to 80% seen with 60 milligrams every 4 weeks and 20 milligrams every week dose. And these are the changes in the lipoprotein A level that happen over time. And they followed participants for a duration of 25 to 27 weeks. Based on these findings that were published last year, there is a phase 3 trial, which is ongoing at this point, the LPA Horizon trial, which is studying Pelacarsen versus placebo and focusing on high-risk individuals. So this is a secondary prevention population. They aim to recruit 7,680 individuals. The trial is multinational and is spread over pretty much all continents, 240 locations. And the key kind of takeaway here is that Emory is also a site for this trial, and you need individuals who have cardiovascular disease and an LPA level greater than 70 milligrams per deciliter to be potentially eligible. So this is one therapeutic option which is being currently evaluated to answer the question of the LPA hypothesis, and if positive, will open a new treatment option for our patients who have cardiovascular disease. So the key takeaways from this presentation are lipoprotein A is an LDL-like particle that is covalently bound to apolipoprotein A, which is primarily produced in the liver. And it likely causes atherosclerosis through several non-redundant mechanisms. And elevated lipoprotein levels are associated with ASCVD risk in both primary and secondary prevention settings. And the current clinical practice guidelines are moving towards broader measurement of lipoprotein A. So we'll probably end up seeing more of our patients who have lipoprotein A levels measured. And lastly, PCSK9 inhibitors can decrease lipoprotein A levels by 25 to 30%. And Pelacarsen, which is the antisense oligonucleotide currently under investigation, dramatically reduces lipoprotein A level by 70 to 80%. The ongoing phase 3 trial will help confirm the LPA hypothesis and provide answer to the important question of the causative role of lipoprotein A in atherosclerotic cardiovascular disease. And thank you for your attention, and I'm happy to take any questions.
Anurag, thank you for an excellent presentation. Dr. Wenger has a question about the effect of omega-3 fatty acids, specifically Vascepa, on LP, I assume on LPA levels.
Dr. Wenger, I will have to take a deeper dive into that. I believe it has not been studied because I was recently reviewing the Reducer trial as well as the Strength trial, and they in their supplemental analysis have focused on lipid biomarkers. But off the top of my head, I don't remember seeing if they've looked at changes in lipoprotein A levels. They've primarily focused on things like LDL, HDL, non-HDL cholesterol. But I will take a look again.
Anurag, my question, I guess, is more just make sure I'm understanding you correctly. So, from just based on what I've heard you say, and correct me if I'm wrong, sort of the ideal person to check LPA in, potentially someone in the intermediate risk range, maybe in the 5 to 20% 10-year risk category, not yet on statin, who maybe or maybe not, I suppose if they have an elevated calcium score, it might be less vital, or I guess, and how would family history play into that decision as well as whether or not to check those levels?
Right. Dr. Williams, you are absolutely right on both fronts. In terms of CAC, and I didn't share those results, but we've analyzed this. So coronary artery calcium, if you're measuring it in the population that you just mentioned, risk of 5 to 20% do not have cardiovascular disease. It is the strongest marker for reclassifying risk, and it is the best decision-making aid when it comes to deciding about statin therapy initiation or not, or kind of waiting for a little while. And although we are seeing kind of this joint association between lipoprotein A and CAC, if there is one test that you would do in that population, perhaps CAC would be the better test. In terms of people who have family history of cardiovascular disease, especially with premature cardiovascular disease, checking for lipoprotein A would be helpful in a young patient where you don't have other risk factors, but you have a strong family history. And then you can have the conversation about lowering their cardiovascular risk using healthier lifestyle and also statin therapy if they would be interested in that.
Stan Sherman, Anurag, can you hear me?
Yes. Sure.
The studies that are being done, and lots of times our patients, we don't really get to see them until they're in their 70s. So with the studies and the risk factor modification and everything, at what age group are these studies and all cutting off and just saying, look, we don't need to worry about LPA at this point?
In the phase 3 trial that is ongoing, I'll have to double check, Dr. Sherman, but I think they are enrolling elderly patients, and by that I mean in their 60s and 70s. That study is similar to our usual PCSK9 inhibitor trials, and Dr. Iziadinso just texted that she can respond. Perhaps she's very familiar with the details.
Yeah, thank you, Anurag. Stan, I can respond to that. So the phase 3 clinical trial that we are enrolling patients in here at Emory is enrolling patients from ages 18 to 80, so up to the age of 80. And I want to go ahead and just take this opportunity to thank all of you, many of you who are already on this call who have referred patients to us to both the Heritage trial, which is the epidemiologic study, which is looking at the prevalence of lipoprotein A and trying to determine the distribution of levels of lipoprotein A among patients with CVD, and then the phase 3 clinical trial. And the way Novartis set it up is that we would have to enroll patients in the Heritage trial to ensure that there were sufficient patients at each site before they would allow you to enroll in the Horizon trial. We have done very well with the Heritage trial. We've enrolled 25 patients and are actually in the process of getting authorization to enroll another 25. And then the second, our phase 3 trial starts next week. I would add, if you don't mind, Robbie, to your question about the lipoprotein A levels, we talked about individuals who are at intermediate risk and family history of premature CAD. I would also add it's worth checking, it's recommended actually to check lipoprotein 18 levels if there's a personal history of premature coronary artery disease or atherosclerotic cardiovascular disease, I should say. And as well, if there are recurrent ASCVD events despite being on optimal treatment, so statin therapy. So you know that for some reason, there's some residual risk that has not been identified and is not being addressed. And so in that patient population, it's worth checking lipoprotein A level as well.
Thank you, Dr. Susan.
All right, it looks like we have a comment from Dr. Sperling. Worthwhile to note that significantly elevated LP(a) may be important to identify related family risk beyond an individual patient. And then Dr. Thames says niacin lowers both LP(a) and triglycerides, but has been shown to be ineffective in prevention of events. This raises questions about the roles of LP(a) and atherogenesis in prevention of events. So good points by all. For the sake of time, I think we'll probably wrap up here. And I want to thank Anurag again for an excellent review of the topic and the literature and the pathophysiology and everything else and future directions, and excellent work as always, Anurag. And thank you, everyone.
The preceding program is copyrighted by Emory University.